cord,
There you go.
I can show you that this tissue is totally soft. It's as soft as a piece of gelatin. And so you can imagine if there was a subluxation. Subluxation is when the spinal column suddenly, with trauma, goes one way or another, and the disc or the bone can temporarily compress the green spinal cord that is within it. It just takes a moment to cause, you can imagine, a jerk on the cord and to leave a patient with paralysis. This is very, very soft tissue and very vulnerable. So let's examine the cord now. Let's look up close. I'm looking now at the posterior or dorsal surface, and I can see, and I hope you can, between the forceps are the dorsal or posterior columns with branches of the posterior spinal arteries running along the surface. And if I turn it over, I can see the anterior surface with its single spinal artery. This spinal artery is very important because it provides blood to the gray matter of the anterior horn, to the cortical spinal tract as it descends in the cord, and to the pain and temperature pathway. Whereas the posterior spinal artery, as you might imagine, supplies one or the other of the two dorsal columns carrying proprioception. So damage to the anterior spinal artery, or nothing more than hypoxia during a surgical intervention, let's say to replace a section of aorta, can leave this anterior spinal artery without enough oxygen or blood to supply the cord, and the patient will remain without control of motor function below that level and with loss of pain and temperature traveling in the lateral regions. So now I'm going to open the dura for you. The arachnoid is adherent to the dura, so we're going to look down, as we have been, onto the pia, or the pial surface. Down here, near the cauda equina, we can see the dorsal and the ventral roots, and I'll open the dural sac in just a moment. Here is a dorsal root ganglion on this side. Here is the stub of one on this side. Here is another one on this side. The dorsal and ventral roots are emerging here. Now we're looking at the cauda equina and the tip of the spinal cord. Here's the conus medullaris, and here are the elongated dorsal and ventral roots, and you can see that they are running to emerge. Here would be at one spinal level, probably a lumbar, and here is another one here. If you zoom in close, you can see the roots. Here's one group of roots emerging. Up here is another group of roots emerging. And in between you can see a thin membrane here, the denticulate ligament that anchors the cord laterally and separates anterior or ventral from posterior, which you can't see from this side of the spinal cord. It's good to point out that the cauda equina, these represent both dorsal and ventral roots. Therefore, they are sensory and motor. They have emerged from the spinal cord and therefore are ensheathed in Schwann cells. These are peripheral nerves, so to speak. That is to say, if they were compressed or damaged, but not separated between proximal and distal end, they could regenerate. So damage to the cauda equina roots gives you the option or the possibility or the potential that these axons can regenerate down through the Schwann cell tubes that are left behind. Whereas damage to the cord at this point with our knowledge is basically irreversible, but sometimes some of the pain and temperature fibers are spared along the edges.
All right, so let's look at a cross-section of the spinal cord. And this goes back to, I believe it's page 36.
I think we need 34.
34, okay. Actually, I'm looking for the list of structures.
Did you want me to put it up there? Thank you guys. You're psychic.
So the cross section that I'm going to draw and use and label is those list of things are on page 36. So we talked about page 34, and there is a diagram of a cross section on 34. But 36 is what you're going to want to draw on as I diagram what we see over here on the spinal cord. All right. So this would be the vertebral body, which means that this is the anterior aspect of the spinal cord. And the spinous process would be on the back side of the screen where we can't see it. So in the spinal column and the brain, our terms anterior and ventral and dorsal and posterior can be interchangeable. I don't know why, except that's the way I grew up with it. I will talk about the dorsal root ganglion, but the posterior gray horn. You're welcome to call everything posterior or everything dorsal. I recognize it's confusing, but that's just what comes out of my mouth. And if you want to write down the same thing, everything posterior, everything dorsal, or so on, that's fine. So when I draw a root, and I say this is the dorsal root, it's really a whole cluster of rootlets. And I'm just drawing one of those rootlets. Okay, so when I'm just going to draw a single component, it'll look like that, but there's several that are involved in one single root component structure here. And then that joins together and forms a spinal nerve. And the spinal nerve is formed of two branches. So there's not a very wide segment. It is actually identified as a spinal nerve. And then we have the rami, the dorsal and the ventral rami of a spinal nerve. So the spinal nerve itself component is very short. So I'm going to leave this on the board. I'm going to draw a larger diagram on the screen. I'm going to draw a larger diagram and label its parts. You might find it easier to take a picture. All right, so the spinal column is identical left and right. And what the H shape in the middle here is gray matter. Do you remember what forms gray matter? Cell bodies. Okay. And so if we have a collection of cell bodies inside the central nervous system, these are going to be nuclei, and we're not going to learn the names of the various nuclei. This is a collection of cell bodies outside the central nervous system, so it's going to be called a ganglion. All right. Now, before I name those structures, I want to put in sensory and motor neurons, so you have an idea how we follow this pattern that I said earlier. We tend to have sensory structures are posterior, and motor structures are anterior or ventral. Okay. So I'll just give a moment for you guys to diagram this, or you can just wait. Okay. So green is going to be sensory. In case you don't know what color I'm using. And this region right here is the spinal nerve. All right, it's going to have two branches. So let's say that I'm touching something with my hand, and that sensory input, that neuron carrying that electrical current triggered by touching something, is coming in from my hand, from the receptor, and going to go posterior, because posterior is sensory, and it's a pseudo-unipolar neuron. Remember, our neurons were pseudo-unipolar, and so its cell body is what forms this swelling of gray matter. Many of these neurons will come into the spinal cord and stop and synapse with another sensory neuron that's going to cross over to the opposite side and ascend to the brain. Okay? So remember when we talked about our sensory pathways, and again, we're going to go over this entire pathway on Friday when we do our sensory pathways. So you're going to see this over and over. So this is our first order neuron. Do you remember that term? I said there were 3 neurons in sequence with the sensory pathway. All right, so all cell bodies of first order neurons are found in this collection right here. All second order neurons are going to cross, except for some of our visuals. All the other ones are going to cross over, and this is going to go up to the thalamus. Remember, the thalamus was gray matter formed by the neurons of the third neuron pathway in the pathway. Now, some of the neurons that are coming into the spinal cord come from a very narrow region, about 4 inches on either side of my spinous processes. I'm going to put my hands like that between my thumb. So skin and muscle, somatic motor, not muscle motor, but knowing what my muscles are doing, or if my muscles cramping, or just itching or temperature on my skin from this area up to the base of my neck, right about there, is going to be carried by this very narrow branch. The rest of my trunk, all of my upper limbs and lower limbs, that sensory neuron is going to come in this branch. That's why this one is so tiny. So if we look over here, that small branch is the dorsal ramus, and it's carrying information from just that narrow region of the back. Okay? And the rest of the trunk and upper limbs is coming in the ventral ramus, which is larger. So if I draw in, let's put a label here, let's say this is back, this is hand, and this is middle back. So it's going to come in the dorsal ramus. Its cell body is also going to be found here, and then its neuron will come in, and this will cross over to the other side and ascend to the thalamus as well. So I'm going to have a whole column of ascending fibers for pain and touch and temperature on the opposite side of where it came into the spinal column. There are some fibers that tell me or carry information for what position my joints are in, whether they're flexed or extended, or discriminatory touch. So if I put my hand inside a paper sack, I can tell if the fuzzy structure I'm touching is a ball or if it's a peach. All right, I can discriminate between those fuzziness. That kind of information will cross over, but not yet. Its cell body will be here, and instead of stopping, it's going to go into this white matter here. I didn't put as much more space, it should be there, but it's usually about this size. Okay, so that's going to go into that white matter, and all of that white matter is going to go up to the brain and be processed for that kind of joint perception. So this entire pathway here is sensory, and it's also going to go to the thalamus. It actually is going to the medulla first. So everything in green is sensory. The same thing would be happening on this side. Okay? So sensory, remember our term is afferent. So it's coming into the central nervous system or going from the central nervous system, the spinal cord, up to the brain. So now let's say that I decide to respond to that feeling. Maybe I'm burning my hand, so I decide to move it back. So I'm going to do a motor response. I'm going to consciously decide to move my hand. So where do we find the cell bodies of our upper motor neurons? In the gray matter of the frontal lobe. Anybody remember what gyrus? Pre-central gyrus. Okay? So that's going to cross over. It's going to, for my right hand, or my left, this is left side. For left side, it's going to start on the right side of my brain and cross over in my brainstem. We'll look at that today. And then it's going to descend in the white matter of my spinal cord and move into my anterior gray horn. Remember, motor is anterior. And cell bodies located here are going to leave and go to my elbow, my triceps, different muscles in my arm, and cause it to move. If I'm going to stand upright in a different section of the spinal cord, muscles would go out to my back and keep the muscles of my back upright. Deep muscles that are found right along either side of my vertebrae.
So is there left and right? Or is it all?
Both of this will be on both sides. I'm saving this side to write labels on.
Oh.
Okay? So yes, you would see the same thing if I was going to move the right side of my body. Then I would have descending motor fibers here, coming into this gray matter and going out this side to go to the right side of my body.
For the motor, but the sensory?
Sensory would come in from this side of the body,
Okay.
cross over, and go up this side.
Oh.
So what I've drawn here would also be here, and what I've drawn here would also be here. So I'm just doing one side, but you would have everything on both. As you can see in, I just didn't want to be that complicated, but if you insist, I'm ready for you. Okay? So yes, I would have both sensory and motor on this side, both sensory and motor on this side. Only sensory in the back, and in the front here I have both sensory and motor.
So for the motor, it goes down the right side, goes down the right side.
So if I'm going to move the right side of my body. The descending motor would have already crossed over because it does that in my skull.
Okay.
And it would be in the spinal cord on the right side of my body. For sensory, most of that crosses over at the level it comes in. So for sensory, it'd be in the opposite side of the spinal cord. But we'll look at that on Friday when we actually do these pathways. Okay.
Back is the dorsal ramus, front is the ventral ramus.
Uh-huh. All right, so one more matter of gray. And this is the lateral horn. I'm going to label these in a moment. This is for autonomic, so to make my heart go faster, I'm going to have a motor fiber, but it's still motor, so it's going to come out the ventral root. And this would make my digestive system go slower, but it's still motor, so it's going to come out that ventral component. So with that in mind, now let's label these structures, okay? And I think to make it cleaner, I'll just put numbers on there. Pardon? Well, it would, but I know what it is. So. I am getting a headache, but. All right, so can I erase this part right here?
Yes.
Okay.
We're good.
So I'm going to just put numbers on here. So this first area right here, all of this right here, all of this right here is going to be the spinal nerve. And the spinal nerve is just a short segment before it divides, and it's either formed or formed by its two branches. And the two branches of the spinal nerve are the dorsal rootlets, or dorsal root, and the larger ventral root. I'm sorry, I said root. Rami. So 2 is the dorsal ramus, and 3 is the ventral ramus. Now, before we go any farther, root is actually this structure here. Before we go any farther, is the spinal nerve sensory or motor or both? The spinal nerve, does it contain only sensory or only motor or both sensory and motor? Both. Okay? So, it's going to be both sensory and motor. And actually, let me draw that in blue. And the dorsal ramus is both sensory and motor. So both, and both. If I cut the dorsal ramus, I'm going to lose sensory and motor to parts of my back. If I cut the ventral ramus, I'm going to lose sensory and motor to parts of my upper extremity or lower extremity, depending on what level of the spinal cord I'm at. Then remember, this is where I have the cell bodies for my sensory neurons. It's a collection of cell bodies outside the central nervous system. So this is known as the dorsal root ganglion. Ganglion because it's outside of the spinal cord. Sensory, motor, or both?
Sensory.
Sensory. And then the central processes going into the spinal cord form the dorsal root, which is also sensory. So I have a student at Sac State whose dad had a stroke. No, mom. Mom had some problems, and she had some surgery, and they left her in a position for a long time, and now it really, really hurts. And pain medication doesn't do anything for it. It's kind of between her scapula and her vertebral column. So surgery would be done to go in here and cut the sensory tract, but then she would lose all sensation from everything from her feet up on that side of the body. Or they could just cut 2 or 3 of the dorsal roots, and then she would have a numb area 2 to 3 inches wide in a strip all the way around her body on that one side. Okay, so that could limit the loss of pain rather than losing everything coming into the body up to that point. Now we have the ventral root. That would be this area here. And that is going to be motor, both voluntary and involuntary. The lateral horn is really only for a short, half the spinal cord. All right, so that's outside. Now we're moving into the spinal cord itself. And so we go back to posterior structures, and this whole area here, all of this portion of our H shape, is the posterior gray horn. So all of this, not just for the 7-inch, but all of this is posterior gray horn, or dorsal gray horn if you prefer. Sensory or motor, or both? Sensory. It's made up of the cell bodies of our second neurons in the pathway. Then we have our lateral gray horn. And the lateral gray horn and the anterior gray horn are both motor. All of this area here is anterior gray horn. Poliovirus attacks the cell bodies of these neurons in the anterior gray horn. This is the central canal, lined with ependymol cells that we've talked about already. This band of gray that connects each half of the H is known as the gray commissure. And we don't assign it a sensory or a motor function. And then we have our white matter. And these are formed of ascending bundles of ascending and descending axons. So out in the nerves, they're all mixed up. I couldn't say that on this side of the nerve would be sensory and on this side of the nerve would be motor. Okay? But our tracks are distinct. And we'll see that on Friday. So this entire posterior column is known as the posterior or dorsal white column. And as you can see, it's all sensory. Suppose I could put a number there. So that is going to be sensory. That's what I've shown here. And then we have the lateral white column. All of this would be the lateral white column. And that one is both. And then here in the front, we haven't talked about it much, but we will on Tuesday next week. This is the anterior white column. And it is also motor. Sorry, it should be both. And the anterior white column is also both. And then fine, yeah.
I'm just curious, looking at your drawing to the right,
Mm-hmm.
how is it the lateral and the anterior white column? I only see the red motors going.
Okay, that's because I was trying to keep this side clear to write on.
Okay.
But if you look at this diagram, sensory is crossed over and is ascending.
Okay,
Motor, which is already crossed over, is descending. We have both sensory and motor.
okay.
Okay? And then I didn't talk about, so 85% of the motor crosses over in our brainstem. The other 15% comes down in the anterior white column and then crosses over. And then we have some other sensory pathways I haven't talked about. So anterior white column is both, and then this area right here, where these green fibers are going, is known as the anterior white commissure. It's primarily sensory, but I don't mark it as either one way or the other. You don't have to assign it a function. So that's spinal cord. Okay? We're going to use some of this today, why I wanted to cover it today, and we're going to come back and look at it extensively and where these fibers are coming from and where they're going when we tie everything together on Friday and Tuesday, because that's what we're going to be doing, is tying all of these structures and fibers and pathways together as we finish with the sensory and motor pathways.
I mean, my book, my numbers are different.
The fibers, remember? This morning.
No,
It's similar.
maybe, but not the same.
I remember that though.
It's different. I don't know what it's called.
Maybe it's recorded with time. I'm very hostile.
Actually, before we start midbrain, before we start brainstem and go for another while, this is probably a good time for a short break. So I know we started off with the video, but why don't you just take a real quick break till 11:30, and then we'll come back. And identify general functions and structures on these components. It helps to know why they are where they are, what makes them. So while we're going to do the formal discussion of the pathways on Friday and a little bit on Tuesday of next week, remember I said we're going to go over this over and over and over, and each time you're going to understand a little bit more, maybe not a lot more, but a little bit more of what we talked about the day before. If nothing from today, at least we'll make last week's material a little bit clearer. All right, so this is going to be a sensory pathway to a post-central gyrus.
What page did you say we were on?
We're starting with brainstem, so whatever that starts on 90.
Sorry, we're all split page through over here. Yep, 94.
And you said there was an extra one.
There's an extra one at the very end, just before 127. There's an extra one. So on Thursday and Friday, we're going to be drawing diagrams. We're putting the neurons on this pathway, which is what I have on the board. But then on page 127 is one all by itself. You can photocopy and just, or you can go online. You can use that one now, or you can go online and make extra copies of it. Okay? So if we're looking at the post-central gyrus, what lobe would we be in?
That's the frontal lobe?
Nope.
Temporal lobe.
Parietal lobe. Parietal is sensory for pain, touch, temperature processing. So we've talked about the 3 neuron pathways. So now that we've talked about our spinal cord, I'm going to draw this neuron in again. This is just so I can show you where these structures are in the brainstem. My purpose for drawing this pathway is not to learn the pathway itself, but to learn why we see what we do in the medulla, the pons, or so on. So a sensory neuron coming in, I'll stay on the same side that we were before, coming in from the upper extremity. It's going to come in and have its cell body in the dorsal root ganglion. That's what we just covered when we were talking about the cross-section of the spinal cord. It's going to send its central process into the posterior gray horn. And most of them are going to stop there, form a synapse with the second neuron, in the pathway. That's what makes our posterior gray horn, is the cell bodies of the second neuron. And then that second neuron will cross over to the opposite side and will pass up through the spinal cord into the medulla, and through the medulla into the midbrain, and through the midbrain to the thalamus. And then I said that our thalami are formed for the most part of the cell bodies of the third neuron in the pathway. And it will go over to the post-central gyrus for processing and actually interpretation as pain or touch or temperature. All right? So we're going to go through this pathway on Friday, name it and talk about the structures. Now, I also talked about a neuron that came in to the spinal nerve, but this one did not cross over to the opposite side. It went into the posterior white column, and then I just said it went up to the spinal column. Here's what it does. It goes up into the medulla, and then it goes to the back of the medulla and synapses with the second neuron there. So these are gray bodies. Would they be ganglia or nuclei? These collection of cell bodies in the central nervous system. Nuclei, all right? Their second neuron is going to cross over and travel up the brainstem, and its third neuron will also go to the post-central gyrus. Okay. So the dorsoroot ganglion is formed by the cell bodies of the first neuron. The nucleus gracilis and cuneatus, we're going to talk about in the medulla, is formed by the cell bodies of the second neuron of a different pathway. All right? This is called a ganglion because it's outside the central nervous system. This is called a nucleus because it's inside the central nervous system. Okay? All right, so those are sensory components that we're going to see in our brainstem structure. And now let's look at a basic motor pathway. So if I'm going to move my hand, that neuron is going to start, we'll do it on this side. So it's going to be in the precentral gyrus. And we have an upper motor neuron. It's going to come down. It's going to pass through my midbrain. It's going to pass through my pons. And it's going to get to the front of my medulla. At the very end, just before my medulla becomes spinal cord, these fibers are going to cross over to the opposite side and descend in the lateral white column before they end in the anterior gray horn. And then my second motor neuron, my lower motor neuron, will go out my spinal nerve. Yes?
Were those like the projection fibers?
Uh-huh. Both of these sets are projection
Because
fibers.
they cross over at the
Not because they cross over, but because they're projecting up and down, either up or down.
up or down
The spinal brainstem and spinal cord. Okay? So having this up in place now, let's look at the structures of the brainstem, and having this map will help us understand why some of those bumps and columns that we see in the brainstem are present. So in your lecture notes, on page 96, there's a series of structures on of the medulla. It looks kind of scary. Talk about getting a headache. All right. I have a lot of information there, and we're only going to talk about some of it today. Okay, so you might want to just put highlights on it. We'll come back and talk about the cranial nerves on Thursday, and we will talk about the pathways on Friday. So it's going to take us a few days to get over all of this information. All right, so as we look at this sagittal section of the brainstem, remember the embryonic vesicles that are involved? Brainstem is midbrain, pons, and medulla. So midbrain is mesencephalon, pons is metencephalon, and medulla is myelencephalon. Okay. The cerebellum, where I have separate lecture notes for, but I'm going to have to talk about it in this pathway. It grows out of the roof of the fourth ventricle. So it develops from the same embryonic vesicle as the pons. So on the diagram, here's the cerebral aqueduct, and this region from here to here is the midbrain. This region from here to here is the pons, and this region from here to here is the medulla. Okay, and we're going to start with medulla, the medulla oblongata, because we have medulla in the kidneys as well. So what's shown here in red is the medulla. It has an upper portion that is similar more in pattern to the pons. The lower portion is more similar to the spinal cord. All right, so it has these two components. And this is from Netter's. This is a ventral view. Remember, ventral is more likely to be motor or sensory? Motor, okay? And so when we look, let me raise my image up a little bit higher here for those of you that are in the back. So this is medulla right here. This is pons, and this is midbrain on each side. These would be the mammillary bodies that are part of the hypothalamus right here, the pituitary gland and optic tracts. So notice these two long columns on the ventral surface of the medulla. They are known as the medullary pyramids. They are ventral, they're anterior, so they're motor. So here's our upper motor neuron, and it passes down through the brain stem, and some of them are going to stay behind in the pons. We'll get to those in a moment. And they get to the pyramid. So that's what the medullary pyramid is. It's these upper motor neurons that are going down to the spinal cord. And where they pass through the medulla, they form this pair of ventral columns. And that's what the medullary pyramids are. They are made up of columns of upper motor neurons. Now at the most distal end, just before the pyramid changes to become the spinal cord, right here you can see a little bit of crossing. So the upper motor neuron is going to come here, and it's going to cross over and descend on the opposite side in the lateral white column. And so that's where 85% of these motor neuron fibers cross, and that's called the decussation. Crossing. Crossing over the motor fibers. Okay, but it's the inferior end of the medulla where that takes place. But these right here, this is the midbrain, but it's also formed of those same motor neurons. They pass through the pons, and when they get to the medulla, that's what forms those medullary pyramids. It's on the front or ventral surface, because that's where we find motor structures. So let me write that in here. Use blue, so it stands out a little bit. So this is going to be the medullary pyramid cut in cross section. Okay, so we can see it here. I'll come back to the posterior view in a moment. You can see it here in this colored image. So the medullary pyramids on the front. You can see it here in the model. So this would be the pons. Here's the insula, and pons, midbrain, and here's the medullary pyramids in the model. Okay. And here they are here. So that's motor descending. Okay, passing through the pyramids. Now, if we look at the back of the brainstem, so I'm going to go forward through the slides. So as we look at the back of the brainstem now, we see the fourth ventricle. Remember, the fourth ventricle is diamond in shape. So the lower half of the fourth ventricle belongs to the medulla. The upper half of the fourth ventricle belongs to the pons. In this lower part of the medulla, the fourth ventricle looks more like a central canal. So it's much smaller as it blends into the central canal. Okay. Then we have some sensory information that's passing up through the medulla. So let's look at a cross-section of the medulla. Here's the medullary pyramids. Here's the fourth ventricle. Okay, and with the nuclei I'm going to draw are a little bit higher than this. But notice what happened for our sensory nuclei coming from the posterior column. It comes in, does not cross over until it gets to the medulla. And then it synapses and forms these sets of nuclei. Notice where they're located? In the back and the dorsal region of the medulla, because they are sensory pathways. And so these groups of nuclei are known as the nuclei cuneatus or gracilis. One is sensory information coming from the upper limb, the other is sensory information coming from the lower limb. Okay. Gracilis happens to be in the center, and cuneatus, the upper limb, is more lateral, lower limb is more medial. So those are sensory nuclei. They're the equivalent, if you will, of the posterior gray horn in the spinal cord. But they're just for this posterior column. Yes?
What's the last word there?
Gracilis?
Gracilis.
Gracilis or Lus. Okay, and that's sensory information for joint position coming from the lower limbs. Now, some of this sensory information doesn't go to the thalamus. On Friday, we're going to look at some spinocerebellar tracts. And so some of this sensory information is going to come in, and it's going to go to, some crosses over, some doesn't. It's going to go to the cerebellum. Doesn't go all the way up to the brain. So that means we're not conscious of it. All right? This band of white matter going into the cerebellum is known as a peduncle. We have 3 cerebellar peduncles. The inferior, cerebellar peduncle is part of the medulla. It's very, very small. It is sensory. And you can see it cut in cross-section here, but that's not what I'm going to ask you to identify. So let's look at, it's just a small part here. This major band of white matter is associated with the pons, and just a small portion on its edge is the inferior cerebellar peduncle. Okay? It's kind of hard to find on the models. I usually have to draw it in. And so when we get to the middle cerebellar peduncle, I'll kind of show you where it is. The cerebellum, as we're going to start now talking about it, you have a whole sheet on it or a special page on it, but the cerebellum, I'm just going to introduce it to you so you understand when I'm talking about the peduncles, what they do. It is a center for coordination and balance, as if I was just to say it in one sentence. So from my eyes, information goes to my thalamus, and then from my thalamus goes to my occipital lobe, so I process and see a vision, see an image. Not visions as in dreams, but see an image. From my thalamus, information also goes to my cerebellum. Now my cerebellum doesn't process that as an image. What it does process it is information coming from my eyes. Okay? From my inner ear, there's fluid. And when I spin, that information, that spinning fluid causes neurons to depress and currents to form, and that information goes to my cerebellum as well. From my joints, joint sense. I can tell whether my limbs are flexed or extended. I can put my fingers behind my head and, well, it's not very close, but I can touch my fingers, all right? And we can do it here. I can know where, I used to do this with my kids in the car. I never closed my eyes, but I would have them close their eyes. So touch the back of my forearm. I'm going to close my eyes. It's like I said, I didn't close my eyes when I was driving. And just make a nice dot. Okay, she didn't make it very hard, so this is going to be difficult. So I have to remember where I felt that dot. And I have to know what my hand is doing. I have to know where this hand is in space. All right? So, all right, so that was, of course, having a nice fat dot helps. So that is about 3/4, half an inch apart. That involved proprioception. All right. Now I can tell you what position my arm was in, but to guide this hand to come over, the cerebellum had to know as well. So the cerebellum works with incoming sensory information, telling the cerebellum what position my joints are in, and that's what's carried by the inferior cerebellar peduncle. As we'll see, I also have descending motor information going to the cerebellum. So as I move my hand around, that information is going to the cerebellum as well, and it's blending that information together. If I need to make an adjustment, the midbrain peduncles will send that information back to the cortex to say you're too far over. Well, it doesn't actually say that, but it adjusts the movement. So someone who has a cerebellar tumor, all right, or other damage can have a cerebellar tremor in which the hand shakes. The harder you try to do something, the wider the swing is. So if I reach out to pick something up, I can do it smoothly. If I have a cerebellar tumor, that gets worse and worse and worse the more I try to focus in and grab that. It's the exact opposite of Parkinson's. So in Parkinson's, they may have a shaking of the hand, or Muhammad Ali when he was trying to light the Olympic flame in the 96 Olympics in Atlanta. You wondered how he was ever going to even get there, but as he actually went to light it, his shaking diminished. So I talked to my folks yesterday, and my dad's had a bit of a tremor in his hand for quite a few years. He says it started last year. I'm like, Dad, you've talked about this for 3 or 4 years. And my brother-in-law gave him a machine to exercise his hands and said it would help the tremor. And I said, I don't think so. He said, Dad, when you, and it bothers him because he teaches the Bible study class as a retired minister. When he's up front, you know, he's just got this little, it's just not even like that. It's just a little, like that a little bit. And I said, so when you go to pick up a paper or to open your Bible or to pick up a glass, does that get worse or does it disappear or start to disappear? It gets better. He said, sometimes it disappears. So I said, you just talked about that in class as part of your brain. I didn't tell him, but it was globus pallidus. And I said you could treat it by getting it zapped. If you wanted to have that done, but if it doesn't bother you that much, I wouldn't interfere with my brain for just something like that that's not, you know, but I said exercising is not going to hurt it, it's not going to help it. It'll just make your hand stronger, but it's not going to do anything to the tremor, okay? So when we decide to do something, then with Parkinson's, that tremor actually gets better. So it's there unconsciously, but then when you go to do something, it decreases or disappears. Cerebellar, the tremor gets worse. Okay, so the more focused you are, the worse the tremor gets. Now, to illustrate how all this works together, you need at least two. You need vision, hearing, and, or the inner ear, not hearing, but the inner ear, and your joint sense to maintain. You need 2 of those 3 to maintain your balance. So if I had a viral inner ear infection and I closed my eyes, I would start to lose my balance because I wouldn't have vision and I wouldn't have the inner ear. Okay. Again, if I had lost my proprioception and I closed my eyes, same thing. So I'm going to illustrate to you how that, yes?
I was just going to comment, that's why they do DUI checks like that, because it's the first one that goes out.
With the alcohol effect.
Yep.
Yeah. So I'm going to spin with my eyes closed, so dancers that are ice skaters and stuff, they always focus when they come around. I'm not going to do that, so I'm going to close my eyes. And then hold up a pen. I'm going to reach out and try to touch it, okay? So you're going to see a quote-unquote argument between my cerebellum getting information from the fluid moving in my ears. Because when I start to spin, once I get going, that fluid's going to be moving. And when I stop spinning, you can rest your hand. I'll just put it when I start to spin. When I stop spinning, that fluid's going to still move. My cerebellum is going to think I'm still moving. But my eyes are going to focus and go, no, the object you're touching is here. And the cerebellum is going to say, not really, but say, no, you're over here. All right? It's going to do that with my hand. It's going to do that with my eyes. You're going to see my eyes going back and forth as my cerebellum moves it, and then my eyeballs voluntarily move it back again in a reflexive movement. All right? So that's called nystagmus. And it also is an indication of competing information. So I did throw up or fall down this morning, so we'll see if we can do it again. So those of you, I'll look at groups of you, look at my eyes. Okay? But I'm going to try to touch this pen. I lost the table this morning. I have to stop and find it again. Okay. Now see how my finger is drifting?
Jeez, your
Look at
eyes.
my eyes, yeah.
Dude, the eyes are crazy. Wow.
Put them in now. Okay? Okay, so we'll look at that again when we talk about it here. But, so the cerebellum is getting sensory input. When I put my hand out, it's competing, it's trying to tell my finger what to do by the information coming in, and that information is contradictory. Okay? So the first part, we have 3 cerebellar peduncles. The inferior leads from the medulla to the cerebellum and is carrying joint sense from my body. All right? So far we've talked about the medullary pyramids, the nuclei gracilis and cuneatus, inferior cerebellar peduncle. Within the medulla as well, and it's not a structure that you're going to find, just recognize it as a component. We look at this cross-section. Here it says reticular formation. Remember the reticular activating system we talked about that wakes up the body? So it's part of that area. But most importantly, it is areas that trigger, I don't want to say trigger, it's part of the autonomic nervous system components where the heart rate and blood pressure center are. Involves the hypothalamus, but the center is here in the medulla. So as blood pressure rises, it'll trigger your heart rate to decrease its force and a number of beats, so blood pressure will come down. If you're losing blood pressure, you're bleeding out, it's going to trigger an increase in the heart rate, all right, to try to keep the blood pressure up. It's also an area called the respiratory center, where there are receptors that are sensitive to the amount of carbon dioxide in your blood that actually moves into the CSF. As the CO2 levels go up, the CSF becomes more acidic, and this triggers you to take deeper and more often, to breathe more often. So you can live without the cerebral cortex. You can't live without the medulla. All right, so babies have been born that have very, very large ventricles and little to no cortex, but a brain stem. They're called mere anencephalic. They used to be called anencephalic, but they still have at least part of a brain. So they would still have the brain stem. And I used to work labor and delivery. I worked about 6 months in 2.5. 6 months worth in 2.5 by working 7 to 3 and 3 to 11, and then coming back at 7 and working 7 to 3, and then coming back at 11 and working 11 to 7 and 7 to 3. So basically all I did was work. But I did labor and delivery and postpartum and nursery. And one of the last weekends I worked, a woman came into the emergency room. She was divorced, had not had any prenatal care, and she was pregnant and in labor, so they called the obstetrician. And he sent her up to the 5th floor, which was the labor and delivery. Another nurse and I admitted her and put a fetal monitor on the baby's head. And the baby's heart rate started to drop. It was about 120 when she came in, and within 10 minutes it had dropped below 90 beats a minute. So we called an emergency C-section, which means the mother goes under general anesthesia. They just make a cut down the abdominal wall. They don't do a nice little bikini cut. And the pediatrician and extra nurses are called in. I still remember the doctor was a little short doctor. He had to get up on a stool to do the surgery. And when he pulled this baby out, the back of the baby's head was slanted back like this. So it didn't have any skull development here. It had flippers for upper extremities and flippers for lower extremities. Otherwise, looked like a full-term baby. We placed it in the bassinet under a warmer. The pediatrician listened to his heart, and then he gave me the stethoscope. It was very slow, like maybe 10 beats a minute. And then the baby died within about 3 or 4 minutes after we put it under the bassinet. The doctor wrote that it was stillborn without a heartbeat. I guess he didn't have to defend, no resuscitative measures. We had an earlier baby, about a 28-week baby that had similar conditions that had lived for about 3 or 4 days. Some babies, rare, it's probably less than 0.1%, will learn to walk and talk. I've only heard of 2 or 3. They develop their cortical tissue after birth. Okay? But these are more commonly the babies whose hearts are used for heart transplants. The parents by now with ultrasound know that their baby doesn't have the cortical aspect of a brain, decide not to abort it, and someone like my sister who was a pediatric heart transplant nurse, the doctor would talk to them about donating their baby's heart for a transplant. So she worked at Loma Linda. A lot of their patients, the mothers and the parents of both the babies, some would be not born yet, just knowing that there was a condition that needed a heart transplant, or a baby that didn't have a brain, and would fly down from Canada, and a baby would be put on life support, and then its chest open and its heart removed, so that the heart was healthy up until the time it was able to be put in the transplant. So that's but they would still have their brain stem. They would still have that portion, allowing the heart to be beating and the brain to the respiratory system. With this particular, just to finish up this particular story, the next day I was working postpartum, which is where the mothers are the portion after their babies are born. And obviously when babies die, the mothers aren't kept on the same floor where they hear the babies crying and nursing and so on. And so I got a phone call from the med-surg floor, 2 floors below us, and they said, were you the nurse that was in the delivery? And I said, yes. And they said, well, she wants to see her baby. And I said, have any of the doctors, the pediatrician or the obstetrician, been to see her? And they said, no, it wasn't their patient. She was just in off the street. So I said, they haven't told her anything? And they said, no, she hasn't talked to anybody, except she knows that her baby died, and she thinks it was a monster that was deformed. So I took a blanket from the nursery, a warm blanket, went to the morgue and got her baby from the refrigerator, wrapped it up so you could just see the face, and went into her room. Her aunt was there, and I held the baby. And they talked about which side of the family it looked like, and they were the ones that told me, well, I thought, they told me I had a monster. And I said, it looks like a baby. And it is a baby. I mean, it has a baby's face. And I opened up the blankets and said, it doesn't have normal arms and legs. I didn't use upper extremity because when I was talking about it, I said, it doesn't have normal arms and legs. But I did pull it back and show the head, and then I gave it to her to hold. She could have pulled it back if she wanted to, but she didn't. And I was so angry because it's like, if she hadn't asked to see your baby, she would have, who knows, your imagination is often worse than what actual reality is. And they were able to recognize family features and so on in its face, and not having limbs and stuff, there's people that walk around, or maybe not walk around, but have those features, and especially with thalidomide, and there's normal people, so that was a little easier for her to deal with it. But, so with respiratory syndrome, recognize if I were to have a multiple choice question, okay, pica, remember our posterior inferior cerebellar artery? If that has an aneurysm, if it ruptures, you're going to lose respiratory and cardiovascular center. It's almost instant death. Okay, whereas the middle cerebral artery or its branches rupture in the brain, you might get paralysis or loss of speech function, but unless it's a huge area, it's not as likely to result in instantaneous death.
Video on YouTube of this little girl that had really severe seizures, like up to 12 seizures a day, and they removed the right side of her brain, the whole entire right side. They showed like this scan of her brain, and it was literally just one side. And she went paralyzed on her left side, but through rehabilitation, she was learning to walk and be able to like use her paralyzed side of her body again.
When they're really, really young, the brain can, part of one brain that normally doesn't do a function sometimes can be taught, will learn to do the function that's, so if that had happened in someone who was 45, it's less likely that they would have been able to get that function back.
Yeah.
But yeah, I saw, there's an article about a baby who had not epileptic, but seizures almost constantly, and they did a similar process to remove those. And the mom was like, I was scared to do it, but the baby wasn't going to live without the procedure. And so that sometimes that makes that decision a little easier. All right, so this was medulla that we were looking at. And now let's move up the brainstem to, and these are the pathways here that we're going to talk about on Friday. Okay, I stuck them in here in the lecture notes, but since I put it on the board, I'm not going to bother looking about them. But this is where we're going to see some of these structures again. So in other words, here's the neuron going, forming the inferior cerebellar peduncle. Okay, so we're going to look at these pathways in more detail on Friday, and having learned these components will make that lecture a little bit easier. All right, so the pons now is just above the medulla, and pons means bridge. Okay, so it's a bridge between the medulla and the midbrain, and it's this area right here. So behind it is the cerebellum, and what we're familiar with the pons is this large swelling that we see right here. That swollen part of the pons is identified as the basal pons, hence the basilar artery, when we were looking at the blood flow to the brain. It looks like a woman who's pregnant, but not to leave you guys out, you can also describe it as a beer belly. Okay, so either way, it's that large swollen region. And here's the reason why. Descending motor neurons, I'm going to draw these on the opposite side here, but they would be on both sides. So we looked at the upper motor neuron where it goes all the way down to the spinal cord. Descending motor neurons, some of them will stop in the pons. And they will send synapse with pontine nuclei, and will send their information through the middle cerebellar peduncle out to the cerebellum. So this is the middle, we do that in blue again, cerebellar peduncle. Remember I said there were three. Medulla has the inferior, and the pons demonstrates the middle cerebellar peduncle. So this is the inferior cerebellar, and this is this big fat one right here. The middle cerebellar peduncle from the back, when we cut it, here's the cerebellum being removed. Here's middle cerebellar peduncle. Inferior is just a small segment on its inferior aspect. So these are descending motor fibers. Instead of going into the pyramid, they stop, synapse with the pontine nuclei, and that's why this is so fat, because of all those cell bodies. And then the pontine nuclei neurons send their fibers into the cerebellum. And this is the upper motor, this is the cortex telling the cerebellum what your muscles are about to do. Okay? So these cell bodies are pontine nuclei. Bless you. Now in the pons, we also have a respiratory center. It's not critical for breathing. You would still be able to breathe if your brainstem was cut between the medulla and the pons, but it would be ragged breathing. It would sound a little bit like the Cheyne-Stokes or apnea breathing of someone who has sleep apnea. Okay? So it would be gasping type of breathing rather than a normal type of breathing when we do have the pons. But you would still have the stimuli to breathe. So we have basal pons, we have the rest of the fourth ventricle, and we have the middle cerebellar peduncle. All right, we don't have any particular sensory structure we're going to talk about. We will be able to see something on Friday, but I'm not going to mention it here because it's something internal. We can't see it. So our sensory pathways are going to pass through the pons. There's no special area where they stop, okay, and form a nucleus. So this would be the ventral pons. And again, the motor neurons are passing through it, but it's fat because we have those pontine nuclei. So on our model, this is the basal pons. All of these white structures here are cranial nerves instead of spinal nerves. We have nerves that come out of the brainstem, and that's what we're going to do on Thursday. So here's the middle cerebellar peduncle, and here's the inferior cerebellar peduncle. Here's middle, and here's inferior. So here's the fourth ventricle. This would be the insula. Here's the fat portion of the thalamus, the pulvinar. And now we're ready for the midbrain. So the midbrain develops from the mesencephalon. Up here. And it's the least modified or changed. So we have the ventricular cerebral aqueduct, which looks the most like the central canal. It's going to be between the thalamus and the pons. And so from our ventral view, or motor pathway, we're back to those upper motor neurons again. And they pass through the front, they form the front structure, so they form this area right here, known as the cerebral peduncles. So it's homologous, if you will, to the medullary pyramids. So it's those bundles of descending upper motor neurons form these two fat tree trunk-like structures that are coming like this and coming together. And those are the cerebral peduncles. Some of them will stop in the basal pons. The rest will pass through to form the medullary pyramids. Same neurons. So this structure right here are the cerebral peduncles. And they're just a bundle of all these upper motor neurons coming down from the precentral gyrus. Some will pass through the pons, some will not. So our cerebral peduncles are bigger than our medullary pyramids because they contain neurons that don't go to the medulla. They stop in the basal pons. Okay. So on their ventral view, and it's motor, so that's why we're going to see it on the ventral view, they form these two wide columns here. The mammillary bodies from the thalamus will be between them. Here they are, you can see a little easier how they're bundles of fibers, and most of them will pass through and then form the medullary pyramid. So it's just one continuous, like a whole bunch of ropes or wires that form the cerebral peduncles in the midbrain and form the medullary pyramids in the medulla. Same neurons. And then here they are in the model. They're hard to find in the whole brain because the hemispheres, the lobes kind of cover up part of them, but they're easier to see in a structure like this, where we're looking at just the, so they're here on the lateral and ventral view, you can see the cerebral peduncles. Okay? Then we have posteriorly sensory reflex components. So that's what's seen on this view over here. So this is the dorsal view. And you see two pairs of swellings, one superior and one inferior. If we go back to this first, let's see if I have it here. If we go back to this first image, kind of the sagittal section. for this purpose. So this is a sagittal view, again, through the brainstem. Here's the beer belly, pregnant belly pons. And from here to here is the midbrain. Here's the cerebral aqueduct. So you can see these two bumps. They're on the dorsal aspect. Because there's two halves, there's actually a total of 4. And so they are known as the 4 bodies in Latin, which is corpora quadrigemina. Corpora for bodies, quadrigemina for 4. So over here on the right, you can see those 2 structures. And on our diagram, it depends on where we cut it. So I don't know if this is the superior one or the inferior one. And I'm not sure what level it's been cut. But the upper one is known as the superior colliculus, colliculi for plural. And the lower one is known as the inferior. Colliculus. The 2 to 4 together are the corpora quadrigemina. Now, the top one is a visual reflex. The bottom one is an auditory reflex. So when I look at something, my optic nerve carries information back to my thalamus. And then from my thalamus, the 3rd neuron goes to my occipital cortex, and I create an image. Okay, we've talked about that pathway. However, some of those neurons from my thalamus don't go to my cortex. Just like some of these motor neurons didn't go down the spinal cord. Instead, they go to the superior colliculus. And from there, they form a reflex with neurons that move my eyeball. So if something moves across my path, this causes my eyeball to move and my head to turn to follow that moving object. More important than a frog that's trying to catch his dinner, all right? But if you're out to dinner with your husband or spouse or girlfriend or significant other, and your head happens to turn to follow some gorgeous person, you can blame it on this reflex. Okay? You tell them I gave you permission, you couldn't help it, it was a reflex. So that's a visual reflex. The inferior colliculus has to do with cervical neck muscles, and if you hear a sound, you turn your head so you can hear better. All right, so superior colliculi are visual reflexes to turn your head or your eyeballs to see better. Inferior colliculus turns your head so your ear is more directed towards that sound. Now you can do that consciously, yes, but it can also happen unconsciously. A few years ago there was a conflict about a woman in Florida who had had a heart attack, and her doctors declared that she was in a vegetative state. She had been an anorexic individual and had really thrown her electrolyte balances off, and then had a heart attack. The family thought that the husband had something to do with this, and when he wanted to take her off life support, he had legal control over those decisions as her husband. The family went to court to try to stop it, and one of the things that they said in proof of the fact that she wasn't really vegetative state was that there were balloons in her room for her birthday or something, and as they moved across the room, her eyes tracked them. So they were trying to say that there was some part of her brain that was still conscious because it was able to track those balloons. And there are certainly individuals who have been in coma for years, 16 years or more, that have come out, and they were hoping for that type of an event. But this is probably the reason why, when all the electrical activity in her brain was mostly non-existent, that this reflex function was still working, and why her eyes were tracking it. She wasn't actually thinking about it or seeing it or making a conscious voluntary attempt to track. All right, so these are sensory reflexes with motor components, but they're found on the dorsal. They form the roof, if you will, over the cerebral aqueduct. So we have the cerebral peduncles. We have the corpora quadrigemina, superior and inferior colliculi. And then just above these, we have something that you're already familiar with. We've seen it in our coronal sections. Let's look at it. Here's the colliculi. Substantia nigra. Remember that's the cell bodies of the neurons producing dopamine that end up in the basal nuclei. So they're modifying tyrosine, the same amino acid that melanin in our tanning comes from, and so that's produced as a byproduct. And so these would be the cerebral peduncles, and then we see the substantia nigra. Here's the cerebral aqueduct, and this would be superior inferior colliculi depending on what level it's been cut. One last structure, we've talked about, so we have one cerebral peduncle, don't get that mixed up. We have one pair of cerebral peduncles, okay? But we have 3 sets of cerebellar peduncles. And so our last cerebellar peduncle is seen right here. It looks like it's part of the pons, but it's the midbrain. So here would be the cerebral peduncle, the middle cerebellar peduncle here. This is inferior, and this is superior. So the superior cerebellar peduncle is neither motor nor sensory. It's carrying the changes that the cerebellum is going to make to your movements based on the input from your eyes and your ears and your joints, and the input from what your motor muscles are getting information to do. So when I move my hand out, my eyes see my hand, my eyes see the object, my ears know what the fluid movement is doing, my joints are sending information to my cerebellum about what position they're in. The middle cerebellar peduncle is telling the brain what my muscles are going to do. And then the cerebellum, like a black box, takes all this information. It makes the adjustments that I need so I don't go too far this way or too far that way. And it sends those adjustments back up to the cortex via the superior cerebellar peduncles. We have connected that, made that connection, and that's what's on the diagram that's on the bottom of page 106. So we've actually talked about that whole pathway on page 106 from the cerebellum. Okay, now I know that was a lot of complicated pathways. I could have just named the structures for you, but I wanted to start to tie in with their functions. So this is what we're actually going to be looking at on Friday. Okay, so we're going to take our time. You have these diagrams in your lecture notes, and we're going to go through them slowly and remind you of what these structures are called and why they're formed as we visit these again. So Friday and Tuesday of next week should not be any new material in the sense of parts of the brain. We'll have the names of the pathways and so on, but we're now going to use the things that we've already talked about and finally start to put this material together. All right, so I'm done with lecture. We're going to have our quiz at the end of lab because making the clay models and stuff will help you facilitate